My proud privilege to introduce both the guests of the President for the AIOC 78th AIOC conference. And may I request Professor Chi to please join me on the dais, and Professor Dua. We have the honor to have two of the most distinguished ophthalmologists in the world today, and Professor Dua is a professor of ophthalmology, University of Nottingham, consultant ophthalmology, Queen's Medical Center, Nottingham. Professor Dua, we all know, has described the Dua's layer, come Dr. Nayak, in the cornea, and really has done path-breaking work. He is an eye surgeon and an academician, and he specializes in corneal transplantation and ocular surface disease, for which he has international recognition. He has served his patients, his students, and his profession in various capacities, which include President of the Royal College of Ophthalmologists, first chair of the Clinical Council for Eye Health Commissioning. He has been the editor-in-chief of BJO, British Journal of Ophthalmology, for 7 long years from 2007 to 2014, President of the European Association of Vision and Eye Research, President of EUCornea, the European Society of Cornea and Ocular Surface Diseases 2011 to 12, and the European Association of Vision and Eye Research. He is also civil consultant advisor to the Royal Air Force and member of the International Steering Committee of Secondary Dry Eye Workshop. He is a member of the Academia Ophthalmologica Internationalis and one of the American Ophthalmology Society. He has recently been appointed as editor-in-chief of the journal EUCornea, which is published by Elsevier, and as chairman of the advisory committee of the International Council of Ophthalmology. He has more than 120 awards and accolades, which include 35 eponyms and award lectures. The Times Higher Education Award and Research Project of the Year, the Rotary Foundation Global Alumni Service to Humanity. He was listed by the magazine Ophthalmology in the top 20 most influential individuals in ophthalmology worldwide, and regarded as one of the 5 ophthalmologists in the list of Britain's top doctors, top 10 doctors, published by the Times magazine. Recently, he was included in the list of 43 of the most influential individuals in Nottingham, 2015, and in the Power list of 100 most influential individuals in ophthalmology worldwide, published by the Ophthalmologist magazine in April 2016. He has over 320 scientific publications, has supervised 42 postgraduate PhD, MD students. He has been endowed with the honorary life membership of the Pune Ophthalmological Society, Medical Contact Lens Society, UK, and Indian Society for Cornea and Keratorefractive Surgery. Apart from this, very recently he has been appointed by Her Majesty Queen Elizabeth II as Commander of the Most Excellent Order of the British Empire for services to ophthalmology, which is indeed a unique honor, and I had the privilege to attend a party hosted by him once he got this this appointment. Above all, I would say he is from Nagpur, and such a humble human being. Despite having reached such very heights, it's always a pleasure to meet him. He has no airs about him, but I have seen him work so hard and so dedicated to the cause of ophthalmology. Really, really, sir, a proud privilege to have you here to deliver the presidential guest lecture. A big round of applause for Dr. Dua. The second person, I have had the opportunity of being together in several courses, several live surgery sessions, both in India and overseas. And I would say that she is one of the most proficient surgeons I have seen, can handle the toughest of situations. Professor Su Fak Chi, who is a senior consultant, started with UVA, but then became the best cataract surgeon, I would say in SNEC. She has obtained her Masters of Ophthalmology degree at the National University of Singapore and was admitted as a Fellow of the Royal College of Surgeons of Glasgow and Edinburgh and the College of Ophthalmologists, UK. She subsequently completed her fellowship in uveitis and oculoplastics, lacrimal and orbital surgery in Moorfields Eye Hospital, London in 1993. Professor Chi's research interests are in cataract, include the management of complicated cataract, such as dense posterior polar cataract. She does a lot of path-breaking work on femtolaser, cataract-assisted, subluxated implants. It's always a pleasure to see her managing the toughest of cases, which all of us would be afraid to handle. She has designed intraocular instruments with facilitate these complex surgeries. In 2018, she was admitted to the International Intraocular Implant Club, and she was admitted, and in the field of uveitis, she has been the president of the Asia Pacific Intraocular Inflammation Study Group since 2013 and member of the International Uveitis Study Group and International Council member of the IOSI. She has over 200 peer-reviewed publications, and in 2000 she was given the Best Teacher Award, and I know that her students love her. In SNEC, and 2005 she became an Asia Pacific Association of Cataract and Refractive Surgeons certified educator. She is conferred by the Singh Health, that is Singapore Health, the Outstanding Clinician 2011 Award and Singapore Health Quality Service Award 2014 for her significant contributions to national healthcare. Most recently, she was admitted as a council member of the Academy of Asia Pacific Professors of Ophthalmology. It is my proud privilege to present before you Professor Su Fak Chi. Please give her a big round of applause. Well, this particular session will have 4 lectures, and they will be alternating between Professor Chi and Professor Dua. So may I request the first lecture to be delivered on CAPSULaser, please.
So good morning, everyone. I'd like to thank Professor Mahipal for this great honor of delivering the guest lecture. So I'll be speaking on CAPSULaser today, and I acknowledge that I received research grant from Excel Lens. Right, so capsulotomy devices out there available to us today are the femtosecond laser, which is an ultra-short pulse time laser. That's CAPSULaser, which is a selective non-contact, non-pulsatile laser capsulotomy device on fast-acting trypan blue stained capsule. And there's Zepto, which is a thermal capsulotomy using a precision or nanopulse capsulotomy device. So what is the ideal capsulotomy? What we want really is to achieve a circular opening of the anterior capsule. We want the ability to center it on the pupil, the back, or the visual axis as it may be. We want it to be sizable. We want it to be precise so that the lens does not tilt over the long term. We want it to be strong, and very importantly, we want it to be tear resistant. And of course, we want it to be quick. So what are the issues with manual capsulotomy? There's a steep learning curve. It also lacks precision in size, circularity, centration, and reproducibility. The anterior capsule tear rate has been reported between 0.79% to 5.5%. And once you have an anterior capsule tear, the posterior extension rate from that becomes 24 to 49%. How about femtosecond laser that has been with us for over 10 years now? There's a cost issue. It has a large footprint. It needs an additional room, except for something like a Zimmer, which is really it's mobile and it can be put in your OR wherever you are. There's additional staff that's required for this. The patient flow issues, integrity and the strength of the capsulotomy has been reported to be 0.1% for anterior capsule tears. How about Zepto that we have been dealing with more recently? It's a contact intracameral device. It needs a certain minimum anterior chamber depth for insertion, especially in small eyes. In Asia, it can be challenging. It has a fixed capsulotomy size, 5.2 mm, and you need unscrubbed staff to assist you with this procedure, and the anterior capsule tear rate is 4%. It's quite high. So what is CAPSULaser? This is a selective laser capsulotomy device that delivers orange wavelength laser energy, which is absorbed by trypan blue stained capsule. During the process of the laser treatment, it actually converts the anterior capsule collagen from type 4 to amorphous collagen. So what I'm going to present to you now are the findings that have been published in the British Journal of Ophthalmology. It's a EPUB. So the aim of the study was to compare the relative threshold forces to initiate an anterior tear for capsulotomies formed by the selective laser capsulotomy of the SLC, the manual CAPSULaser, and the femtosecond capsulotomy techniques. So there were actually 3 study groups in order to compare between the SLC versus the manual CCC, the CCC versus the femto-CCC, the flex femto-CCC versus the selective laser group. So we had actually pairs of phakic age-matched cadaveric eyes that were acquired within 72 hours post-mortem. We removed the cornea and the iris, and then following capsulotomy treatment, the lens nucleus was hydroexpressed and the cortex was aspirated. The capsule was then treated with one of these 3 treatment modalities for capsulotomy, either the SLC, femtolaser, or the manual CCC. Then we used this device here and plotted the load extension curves using this device called the Instructor mechanical tester. So actually you can see a rim here in which the capsulotomy fits in, and it is slowly put on a stretch, and we are able to measure the parameter at which the capsule gives way. Right? And also this is actually stretched by a load, and we measure the load that's applied to it. And following this, the capsulotomy rim structures are evaluated using scanning electron microscopy. So when we compared pairwise between the laser, selective laser capsulotomy versus the manual, looking at firstly the perimeter stretch at which the capsule ruptured, and on the right here, the threshold load that was applied, we found that the selective laser capsulotomy was significantly higher than CCC for both parameters of the perimeter stretch and the load. Comparing between manual CCC versus the femto-CCC, the threshold load of all 10 pairs with the manual CCC exceeded that of the femto, but this was not significant for the perimeter stretch. When we compared between femtocapsulotomy and the selective laser capsulotomy for perimeter and stretch load, we found that the SLC was significantly superior to the femto for both the increased perimeter stretch and threshold load, and you can see clearly there's a great difference between the two. And very interestingly, when we look at the scanning electron microscopy findings, we are familiar with a curvilinear CAPSULaser created manually, a smooth tear here, that with the femtosecond laser, you can see actually little spots here that are representing regions of aberrant holes from the scatter of the femtosecond laser applied to the capsule. And here, interestingly, it's so different to look at the selective laser capsulotomy treatment. We saw a doubling of the edge thickness, a rolled over folded edge, and the edge presenting was actually a smooth edge. And what really was happening here was that there was a thermal change of type 4 collagen to amorphous collagen, right? So you can see there's actually a change here, and this actually contributed to the increased elasticity that we see with this capsulotomy. So when we look at the relative tear strength relative to the manual CAPSULaser that we're familiar with, the femtosecond laser actually was 70% of the strength of the manual CCC, and the CAPSULaser actually was 150% the strength of the standard manual CCC. So you can see, you can place this on stretch between two retractors, and this does not easily rip. So you can see here, courtesy of Sachdev from Germany, just placing two instruments here to stretch the capsulotomy created with this selective laser, and you can see it has not broken. So that means that you can prolapse the nucleus, you can do a lot of maneuvers, accidentally hit it, and yet it is safe. So what does it look like? Well, we have had the privilege of using this in the Singapore National Eye Centre. It is compact. This is all that the laser is. It's mounted under any eye microscope. but it does add to the working distance. It's not good for someone who's not that tall like myself. It is not inserted into the anterior chamber. Its capsulotomy is stronger than that of manual CCC, which is really the best thing about this treatment. The centration is not automated, and you have to look at the Purkinje reflex to center this on the visual axis. Patient flow is not an issue because it's just a step within your surgery. It's attached to the microscope. It's more cost-effective than femto, but costlier than Zepto. So there is a console in which you can control the parameters. The capsulotomy speed is not the fastest, it's 0.3 seconds. The fastest really is Zepto, 0.004 seconds. This is what the console looks like. You are able to vary the diameter of the capsulotomy from 4.5 to 5.5 mm. It's adjustable in 0.1 mm steps. It's consistent, it's precise. The shape is always circular. Sometimes Zepto, we can get oval type of capsulotomies. Interestingly, it cuts actually in this manner, all right? It starts slightly within, and then it has an overlap. It starts with a lower energy, and then the energy ramps up higher, and finally comes one round. And this is in order to treat complex cases like intumescent lens. It's a precaution against patient movement. And this is a thermal laser, and it's not a hole punching laser, and it anneals the capsule rim, creating a double edge. So let's have a look at a case like this. So we put HPMC on the cornea, and this is staining with trypan blue, and this is fast acting and is stronger at 0.4%. And after putting hypromellose again on the cornea, this is a focusing lens and the fixation lens. It's very quickly done with the laser, and you can see this is complete. It's circular, it's centered, and interesting, if you look at the edge, it's a little rough looking because of the double edge that it presents, and it's actually rolled over, and it's really very, very strong. So you can see it's really very nice. It stands out, especially since we have stained the capsule. You can see this edge is really very, very outstanding, and you will not miss it during your maneuvers. So 1 month post-operatively, you will still see that this edge is a little rough looking. Now, I just want to share with you some clinical data that was collected by Pavel Zduka in this clinical study here. We compared between CAPSULaser 63 eyes and manual CCC 62 eyes, and he found that the laser was very accurate in sizing, the circularity, and the centration precision was better than with manual treatment. And there were also no adverse events, and it was 100% free-floating, 360-degree overlap of the IOL at the end of the surgery. And you can see here minimum deviation from the intended diameter, quite different from manual, and again significantly different for circularity in red compared to manual in blue, and for centration the same. And these are some pictures of paired eyes of patients, one eye being done with a CAPSULaser and the other with a manual capsulotomy. And you can see that at 1 year, there's still stable position of the IOL, 360 overlap. And to date, he's treated 3,000 over eyes of all various complexities. And what I want to point out is that this laser does transect the cortex, not unlike femtosecond treatment. And the capsulotomy edge appears adherent to the cortex, but actually is not, unlike femto. There's no increased inflammation, no anterior capsule fibrosis at 1 year. The PCO really depends on the IOL and other variables. Refractive outcomes are stable at 18 months, and it's really an excellent tool for teaching residents because they can stretch it or they can try and chop it, it will not give way. So selective laser capsulotomy is a significantly stronger than CCC kind of capsulotomy, which in turn is stronger than the femtocapsulotomy. The scanning electron microscopy findings actually demonstrate the structural changes which support these findings. And clinically, the SLC may provide increased surgical safety by reducing the chances of anterior capsule tears during cataract surgery. Thank you.
Thank you very much, Professor Chi. Actually, an excellent presentation. I think she's involved in several research projects. We'll now have Professor Dua, and I think that's something what he's going to talk about. It's a lot for us to learn, and that is steering the ship from studentship to leadership. I think learnings from his entire life as an ophthalmologist. Over to you, sir, Professor Dua.
Well, thank you very, very much, Mahipal, and I'm really privileged, honored, and grateful for choosing me as your guest lecturer. I'm also grateful for the very kind words you said earlier on in your introduction. This topic is a very unconventional topic, and the talk itself is very unconventional, as you will see as we go along. These are learning points from my life experience, my professional life experience, that is, and hope to pass on some messages to all of you. Life is the summation of the opportunities that present and the choices one makes when those opportunities present. My first opportunity was in school. It was my first encounter with destiny. I always wanted to join the Indian Air Force like my father, who retired as an Air Commodore. The uniform and the discipline really attracted me. But he said, no, you're going to graduate from university first before you join the Air Force. So it was a natural that I take up a degree in aeronautical engineering and become an engineer before I joined the Air Force. So I took physics, chemistry, and mathematics as my subjects at the age of 14, which is what we had to do then. If you took physics, chemistry, and biology, you became a doctor. If you took physics, chemistry, maths, you became an engineer. So I was in Air Force Central School in New Delhi, physics, chemistry, mathematics. 7 days before start of school, I was in the boarding school. I met a friend, Kanwaljit Singh Serai. We became very good friends. But on the first day in school, in class, he did not turn up. I was very worried, what happened to him? Why didn't he come to class? The first lesson was over, the second lesson was over, and then we had the small break. And I went out and I saw him playing in the playground. I said, where have you been? He said, where have you been? I said, well, I've been in the class. He said, no, I've been in the class. Then he looked at me and said, which class? I said, that one. He said, oh, that's mathematics. I'm in biology, come over. So I picked up my bag and moved to 9B, and then I became a doctor. So that was my first encounter with destiny. Whatever you do, do it well. You can succeed in anything you take on, even if it is not your first choice. This was the Government Medical College and Hospital, Nagpur, India, my alma mater, and very fond memories of my days over there. Through MBBS, in the final year, I met Professor Ishwar, and many in this hall might know him or know of him. It is said by Henry Adams, a teacher affects eternity. He can never tell where his influence stops. Find inspiration and be inspired. He made me sit the MP Ophthalmic Award examination, which was for final year students before you started a career in ophthalmology. It was for everybody to sit. I sat that exam. I got the first prize from amongst the 12 or 13 students who sat that exam, and that was 25 rupees. I then joined ophthalmology, became a registrar, lecturer, and a reader in ophthalmology in Nagpur. And I did my MBBS, DO, MS, MNMS, PhD under Professor Ishwar supervision. So the first thing is do the basics right. Get interested in research. And by research, I mean ask a simple question and try and find the answer if the books don't give you the answer. That is the simplest definition of research, and everybody should encourage themselves or their students to do research to some extent. I have written an editorial in a Brazilian ophthalmology journal because my friend is an editor, is the editor of the journal. He said, can you write me an editorial? And everybody knows this, the eye cannot see what the mind doesn't know. What the eye doesn't see and the mind doesn't know doesn't exist as far as you're concerned. That was D.H. Lawrence who said that. But I took it a step further. There's a difference between seeing and looking. Only when one can look at something and see beyond what the mind knows can new discoveries be made. If we can only see what the mind knows, then we will never see beyond that and never find anything new. That's what happened with Archimedes when he discovered the principle of flotation. That's what happened with Newton when he saw the apple falling and he found gravity from that, and with Alexander Fleming and the discovery of penicillin. So taking a moment to pause and think of what we see is all that is needed to allow the eye to see what the mind does not know. Seek opportunity if opportunity does not seek you. If you don't find opportunity coming your way, go find it. And that was my first opportunity. I was a reader in ophthalmology in Nagpur. I said, I have to go abroad and learn something, because there was a kind of a glass ceiling. There was a kind of an, I've reached where I can here. And I went down to Huddersfield in England and became an SHO. So it's like a game of snakes and ladder. The snake gets you near 100 and you go all the way down. And in Huddersfield, everybody said to me, this is a district general hospital. You must get into a teaching hospital. You will go far if you're in a teaching hospital, not if you're in a district general hospital. So I applied for an SHO's job in Nottingham. This is way back in 1984. I was not even shortlisted. Then I went to Aberdeen, where there was a locum job as a SHO and a registrar advertised. And there I met my first mentor in the UK, but my second mentor after Ishwar Chandra. And he took me under his wing, and I became a registrar with him. He was a specialist in uveitis, so my first interest was uveitis. But the important thing is you find a mentor, befriend him and her, and make it a lifelong relationship. Even to this day, I correspond with John Forrester. I correspond with my other mentor I'll tell you about, but unfortunately, Ishwar Chandra is no more. There, with John Forrester, I came across this patient with a corneal abrasion. And like everybody, I measured the longest dimensions of that. But what struck me was not that there was a large abrasion in the center, but there was a large area of the epithelium in the periphery that had not sloughed off, despite the extensive nature of this injury. And I asked myself this question, why is the glass half full, instead of asking why is it half empty, which everybody does. And then we were able to define the first set of rules of corneal epithelial wound healing, which is that an abrasion like this does not heal by forming circles of reducing diameter, but instead from the remaining intact epithelium, 3, 4, or 5 convex sheets of cells appear. They meet each other to undergo contact inhibition, form geometric shapes, which then close by forming dendritic or pseudodendritic lines, which are essentially Y-shaped contact lines, very much like the sutures of the lens, which is also the meeting point of epithelial cells. And bits of the Y can be missing to give you the pseudodendritic shape or this kind. And this happens consistently every time an abrasion with an intact limbus heals. So take a look here. This one, the convex sheets are coming. You get the quadrilateral shape and then the Y-shaped contact lines. This lasts for a few hours and then it disappears. You take a look here, a nice pentagon of a healing abrasion, the geometric shape, and here's your Y-shaped line. Here's a quadrilateral, and here's your Y-shaped line. So very consistently this happens. This did not require any instrument of any magnitude, just looking with a slit lamp, fluorescein, and you find a completely new pattern of healing which was never described before. But obviously, while you're looking for patients with an intact limbus and an abrasion, you find patients where the limbus is involved. And you look at that closely, and what you find is the second set of rules by which every abrasion with an intact, with an involved limbus will heal. From the remaining intact corneal epithelium, these tongue-shaped projections appear. They migrate in a circumferential direction, as you see here, till the limbus is re-epithelialized, and then it becomes like a limbus, like a cornea with an intact limbus with a central abrasion, and it follows the first set of rules. So take a look here. That is preserved. Limbus from there to there is preserved, but these tongue-shaped projections are starting. They are migrating circumferentially, preferential circumferential migration along the limbus. They move till they meet. In the meantime, the conjunctiva is also migrating in a centripetal direction, and when these meet, then it becomes like an abrasion with an intact limbus. Cornea heals with corneal epithelium, conjunctiva heals with conjunctival epithelium, and normality is restored. And you can see already that contact line beginning to appear, which will eventually become a Y. Take a look at this one here. The same thing, tongue-shaped projections coming in. They meet. There is a line, and there's a triangular shape. When that will move in, it will give you the Y-shaped contact lines as it did, as you see over here. So this is consistent pattern of healing of corneal epithelial wounds when the limbus is involved. But then clinically, what was more important was the third set of rules, that in some cases, before these can meet, the conjunctiva will grow in, and you will get an area of conjunctivalization of the cornea, which is thin, irregular, attracts blood vessels, and is essentially a sector of limbal stem cell deficiency. So here's an example. You can see that much limbus is surviving. This conjunctiva has survived. Cells are growing from the limbus. They are migrating true to form in the circumferential direction, but this conjunctiva has moved in, has crossed the limbus. You've got a mixture of conjunctival and corneal epithelium over here, and then you're going to get a problem, and that problem you will see is that conjunctivalization of the cornea attracting blood vessels and area of stem cell deficiency. All this we did with John Forrester and published papers. And there I learned that your teachers and your trainers will always stand by you. They will back you, they will support you, and you have to cherish this relationship, because this relationship is as important to them as it is to you, because you will carry their name forward, and anything wrong you do will reflect on them. So you have to keep that relationship, that sensitive balance, as you deal with your teachers and your trainers. And you have to become a doctor, in our case an ophthalmologist, before you become a subspecialist. Nowadays, our residents in the third year tell us, I want to be glaucoma or cornea or something, and we say, shut up, first become an ophthalmologist. And learn to walk before you run. I don't have to say that again. Now, having done what I did in Aberdeen, I had the opportunity to go to the States. And from being a senior registrar, which was being just one step from a consultant, I went down to the States and became a fellow. And there I called my mom to say, I'm going to the States now to do a fellowship. My mom said, look, you went from Nagpur, now you've gone to Aberdeen, now you've gone to Huddersfield and Aberdeen, and now do you not want to settle in life? So I told her, there's a difference between stagnation and settlement. If you're stagnating, the water is still settled, but it's not the same as settling in life. And I said, no, I'm going to go ahead, because education and training are priceless investments with lifelong dividends. So I went from a reader to a fellow, half my salary, but I was learning more. So I was making progress in my profession, although not in my bank balance. So avail as many opportunities to learn as you can get. And that is very, very important. I don't know who said this, but it's a very important quotation. A doctor is a student all his life. In other words, when he or she ceases to be a student, he dies. And that's what happens. 80 to 90% of what I do today is not what I learned as a registrar or as a fellow. I had to learn it as a professor, as a reader, and in my career, even to this day. And even from this conference, I have learned few things already, which I will take back and apply. So you are always a student. There I met these other two mentors, Professor Larry Donoso in research and Peter Leibson in cornea in the Wills Eye Hospital. And at that time, this paper had appeared that you get this hurricane keratitis in patients with corneal graft, this whirl pattern of healing epithelial cells, which the authors had said is because of the sutures. And we all believed that. And then this patient came along, no sutures, no graft, and he's got a beautiful whirl pattern on the cornea. So clearly, what people say and claim in books is not always right. And this theme will come up again. Question what you read if it doesn't add up. So here you see this patient with a beautiful whirl, and then we obviously looked at it carefully, and we were able to tell you a vortex keratopathy, which is defined, a whirl pattern defined by pigment, which patients are asymptomatic, and this hurricane where there is staining of the cells and the patients have some irritation, but it eventually disappears, and that's the difference. But both of these, you can see the world is clockwise. And the question here was, why is this almost always clockwise? Why is not random? And we said, well, let's look at the eye. And the eye is a dipole, which is electronegative in the front, positive at the back. 6 millivolt difference current flows from the front to back. And we know that corneal epithelial cells respond to magnetism and electricity and gravity. So there's galvanotaxis, galvanotrophism, and magnetotaxis and magnetotrophism. So it may be that because this is positive and you have the right-hand rule that the current flows from front to back, the electromagnetic waves will be in a clockwise direction of the eye. And that will mean centripetally migrating cells will be diverted clockwise because of the electromagnetic fields. So we said, let's test it out. So we grew cells on magnets, and we found that the cells on magnets, these are corneal epithelial cells, start to form a whirl in culture, and that whirl becomes tightened and tighter and tighter, and then it forms a complete whirl like this. And over time, as the cells grow, the whirl unfurls and disappears into the periphery. So you could make these whirls form in culture on magnetic, with bar magnets beneath the culture plate. And these are some examples, and these I can guarantee you are not of the Whirlpool galaxy from outer space, because this is the Whirlpool galaxy from outer space. So you can see how these cells grow in these whirl pattern, and is a basis, at least one basis for which you might see these whirl patterns on the cornea. While I was at the Wills Eye Hospital in Philadelphia having lunch one afternoon, the phone rang and somebody said, is Dr. Dua here? And I said, yeah. He said, this is for you. And that was a long-distance phone call from the member of the Senate of the University of Nottingham, who said, we have the chair of ophthalmology in Nottingham. Would you be interested in joining? The same place where I was not listed as shortlisted as an SHO. So that was my second encounter with destiny. And the lesson is, no matter how many snakes you encounter in your path, you will eventually hit the ladder, which will take you to the sky, and then sky is your limit. So when you reach a certain level in life, in your professional life, you have to define your niche. Carve yourself a niche. It may be clinical, it may be scientific, whatever, and project yourself at meetings and conferences. The same thing, just to give you one example, where you see this conjunctiva has already grown on the cornea. There is corneal epithelium, there's conjunctival epithelium, there's stem cell deficiency. All you have to do is scrape it away and let it repopulate from the remaining intact epithelium, a technique we introduced called sequential sector conjunctival epitheliectomy, because you may have to do this more than once, and you can see that healthy corneal epithelium comes over the visual axis. Vision improves within a matter of days, and you don't have to do any more as long as the pupil is covered with corneal epithelium, and it became a very simple technique to restore vision in patients like this. From that, we went on to stem cell transplantation, doing limbal transplants from autologous other non-affected eyes, as you see over here. We went on to do cadaver limbal transplants and defined and set up the whole niche. My niche became ocular surface reconstruction, stem cell transplantation, which is what I did as my subspecialty interest for a long time. And in the context of that, we came up with this classification of chemical burns, because the current classification was not up to scratch. It did not meet. It was decided and defined at the time when concept of limbal stem cell transplantation did not exist. So it had to be revisited, and we did that. In dealing with these patients, we had a lot of corneal vascularization. We studied corneal vessels in detail. We came across a lot of findings which were hitherto unknown, and we were able to come up with a technique to completely close these vessels, which we now call fine needle diathermy occlusion of corneal vessels, because even today your anti-VEGFs will not work on mature and established vessels. They only work on active young and active old vessels. So you have to combine fine needle diathermy occlusion with anti-VEGF injection, and that is now standard practice across the world. Here's an example. Again, you can see how that eye with fine needle diathermy becomes like this. All the vessels are gone. And we also came up with this alcohol delamination for recurrent corneal erosion syndrome. You take it away with alcohol 20% for 30 seconds, and you get an 85% plus success rate. But at this point, when you're doing all these things, you are creating new knowledge, you are understanding and applying new knowledge, you should always step back and pause. And this is my favorite quote. To ask a question is the beginning of learning. To answer the question is a test of knowledge. But to question the answer is the start of wisdom. And you have to find answers and you have to question those answers, even if you have provided those answers yourself. Always question those answers. And here it was a surprise to me. All my life I've talked about the limbus and the importance and stem cells, and these patients come along with completely clear corneal epithelium in the center, but completely destroyed limbus. So how can this sheet support itself when there are no stem cells? And we were able to show that the corneal epithelium can regenerate from the basal epithelium in the absence of a limbus in normal physiological state. And it's only when there's injury that the limbal stem cells are necessary. So I had to question my own answers and had to find new answers because what I had done was partly correct and not totally correct. In all of this, you're not alone. Many, many people. Don't forget your juniors, the smallest and the youngest, on to your seniors and your colleagues who are helping you. You are part of a team, and you have to be a team player. I was once in my clinic seeing patients, and a new nurse had just come, and she was a senior nurse, and I saw 3 or 4 patients, and she stood there and then said, oh, seeing that there's nothing for me to do, can I go? I said, no. Seeing that there's nothing for you to do, can you please bring me a cup of tea? And she said, what, me in my blue uniform, you expect me to bring you a cup of tea? I said, sorry, I asked. I said, I make a cup of tea for my wife every day, and if you were working and I was standing here, I'd be more than happy to make you a cup of tea. And then in a flash of inspiration, I said, by the way, 3/4 of team is tea. So if you're going to be a team, you have to make me tea. And she looked at me and said, for that, I will make you tea. And she brought me a cup of tea. So you respect your colleagues. Peer recognition is the highest form of recognition. Your teachers will say you're great, your students will say you're great, but your colleagues will be the last person to say you're great. And when their colleagues say you're great or you're good or you're right, you have arrived. So peer recognition is to be respected. And I got that in many forms. Many people corroborated my findings in research and supported it with randomized controlled trials. And then this last bit everybody knows. We came across this layer, the Duer's layer, the pre-Descemet's layer. We were able to describe 3 different kinds of bubbles, which are now universally accepted across the world, but they were not initially. And I spoke to colleagues here already, juniors who are trying to prove a new point, and they are feeling resistant. That is natural. You have to accept that, and then keep throwing the evidence, not at anybody, but in the literature, in the public domain. And the evidence will speak for itself. You don't have to prove by shouting on the top of your voice. Let the evidence prove that. And this was my eureka moment when we created a bubble of the type 1, and we were able to peel off the entire Descemet's membrane, and the bubble did not deflate. It stayed where it was. We said, there's that layer. This is something special. It's impervious to air, etc., etc. And that was the start of this journey. And this paper was published. It received a lot of accolades, of which one was the Times Higher Education Research Project of the Year Award. And my co-author here, Dalia Syed, is sitting right in the front over here. And here we are as a team, Lana Faraz, Dalia Syed, myself, when we got this award at the Oscar-like ceremony. And the University of Nottingham displayed the Times Higher Education Award banner on its entrance, every gate, and there are about 24 gates. Every gate had this banner, which was there for 2 years. That's again. And then this lady from Paraguay, I don't know her, Kelly is her name. She said, I'm doing a poster for my national congress. Can you send me some literature, your papers, and give me a Skype interview, which I did. And she got a snapshot of that over there. And she made models of different types of bubbles, and she got the first prize. And then she was selected to go to the International Congress of Ocular Morphology and Human Anatomy and Human Morphology. And she won an international first prize for that layer. So it was unknown people, when they ask you for help, always find time to give that help. You never know where it might lead. People were criticizing, well, if it is there, why don't you see it on OCT? Well, then this lady from Waterloo came up and said, ultra-high resolution OCT showed the Descemet's membrane at 2 lines, but there's the layer. In vivo, in living human eyes, she was able to demonstrate the layer beyond the last row of keratocytes, and that's the histological correlation. That's your layer there, and that's the keratocytes over there. So people will eventually bring evidence, people will eventually bring it forward. And I won't read all of this. This layer has helped us tremendously in many different ways, but one way which has not yet been published, but I'll show you in my next slide, is this, that Descemet's membrane detachment, which we all take for granted, is actually completely wrong, our understanding. Descemet's membrane detachment, like the bubbles, is of 3 types. The type 1, where you get the pre-Descemet's layer, or the Duer's layer, and the membrane detaching. The type 2 bubble type, where only the Descemet's has detached, and the mixed type, where both have detached and also separated from each other. The pre-Descemet's layer will spontaneously detach post-cataract surgery, post-chronic edema in corneal grafts, etc. And this paper is under review in the AJO. So we will have to completely change our thinking, because these types of detachments, you can't push them back with an air bubble. You have to put a descemetectomy to release the tension, release the traction in order for it to go back. Don't achieve for reward. So don't say, I'm going to do this because I get this prize, but don't hesitate to pick up your reward if one is going. And rewards will come to you in many different ways, as it came to me. But the funny thing about awards and rewards is soon people start giving you awards because you've got so many awards. And then back because one more, and then you get another award because you've got some. And that's the way it snowballs. And that's the interesting thing. So if there is an award going, you should apply for it. You should contest for it. You should compete for it. No apply, no reply. And define and pursue your ambitions. Have a plan B. So towards the end now, this is the home stretch. Success is 9 times failure. So every time you fail, don't give up. Have a plan B. What do I do next? What do I do next? And you will find eventually you will succeed. As one's career progresses, your emphasis changes and opportunities keep presenting themselves. Peer recognition comes in various forms, and the President, Mahipal, has already narrated to you. And you don't say, I'm going to go and compete. Your peers will push you along because they say, oh, we want you to do this, we want you to do this. And you get up, and I had the good fortune of holding many different posts. That over 49 PhD MSc students, lots of publications, but you do everything with heart and mind, with passion. Try to make a difference. Learn with your students and learn from your students. They will teach you quite a bit. And when you've done one bit, don't sit back and relax. Move on. What next? Think in terms of beginnings, not endings. Take your family along, and sometimes it's a very difficult balance, your work-life balance, but try and take them along as much as you can, and keep your patients as the center of everything you do. You have to keep them at the center. They will teach you more than anyone else can. They will reward you as no one else can. And this is what I wrote in one article for a magazine. They will think you are God. Prove them right. And I'll give you one example. This is a patient with Down syndrome. He was 46-year-old, cared by his brother, and the brother came to me and says, he spends all his time coloring these images. But look, his coloring is going all over now. He can't see. Can you help him? I've taken him to different doctors. They say he's got advanced keratoconus, he's got Down syndrome, he's got cataracts. We can't help him because he had this, he was always punching his eyes. So can you do something? I said, I'll do his cataracts, we won't do his corneas. And that's what we did, and he came back with these drawings. It was such a rewarding moment for me that he suddenly started to do what he only did in life. And we are so fortunate to be in a profession that is so rewarding on a daily basis. We make a difference to patients' lives, and that feeling is better than any award or any prize or any money can buy. And so we have to recognize how privileged we are in our profession. And the last point I make is this. When you've got it all, you must remember you have to pay back. You have to complete the circle. You can never pay back the debt you owe to your parents or your teachers. This is one debt each generation owes to the previous generation, but pays back to the next generation. By doing for your teachers and doing for your students and your children what your teachers and your parents did for you. And this is what I have encapsulated in 3 verses, which I will say and conclude. The finger that I held when I learned to walk, that showed me the words to speak the talk, that turned the pages of knowledge to teach and pointed to stars for me to reach, is part of the hand that waves me on as I grasp the baton and move beyond into the future, living his dream, knowing how much to him it will mean. Time will pass, I'll stand on my feet. I'll extend my hand the young ones to greet, for in their future I will secure the future forevermore. Mahatma Gandhi said, "There go the people, I must follow them, for I am their leader." Think in terms of beginnings, not endings, I said. Every ending provides an opportunity for a new beginning. If you enjoy what you're doing, you don't have to work a single day in your life. That is what Confucius said. Always pursue perfection, but never assume you are perfect. Perfection is an illusion. The achievement is in the pursuit of perfection. The day you think you are perfect, you will have become complacent. Thank you, and have an enjoyable journey towards perfection.
Wonderful, Harminder, and I think I have listened to this third time, and I think he's one of the, he said he enjoyed giving the talk to the 10,000 Rotarians in Portugal, and that's there in the YouTube, so you should Google and see that presentation. And I think every time, as Harminder says, and I'm a student, and every time I think he made a talk in my hospital, and I'm happy Mahipal brought him as a president's guest, and I think he's coming again and again. Probably he says 6 times a year he visits India, and he's not tired of coming. And I think he was in Jakarta with me, and I came back and went one day to Mumbai and came. He went to London and whichever airport, Birmingham, and then come here. So you can imagine it takes a lot of time and preparation to do this, not only travel time, but I think many things, I think time difference. But I'm glad every time I've learned, and I think I've taken photographs of your presentation. So I need your permission to use it. And everywhere I'm happy you've written HSD. So it's nice to, and we'll always acknowledge that. I think everybody sitting here will have gone through that, but nobody makes some notes, and probably you can see Dr. Nayak also was taking notes, and I'm sure even Mahipal was taking notes. I think if you make it yourself, I think you can tell your next generation. And I think, as he quoted Gandhiji, you have to be the change what you want to see. And I think he's one example, and we are proud that we have the duas layer and we have the dua here. And long live Indian contribution starting from Shushruta.
Thank you very much, Dr. Natarajan. I have always loved to hear the journeys of inspiring leaders and individuals, and I think Professor Dua's journey has been incredible. We move on to Professor Chi, and I think watching her videos doing the surgery so deftly in subluxations, dislocations, etc., I think it's really fantastic. Can I have Professor Chi Sufak talk about scleral fixation of IOLs made simple?
Thank you. So I'm in the land of glued IOLs. So I decided to steer clear of this and talk about scleral sutured IOLs instead. My financial disclosures with no relevance. So how can we scleral fixate? We can do it by suturing directly to the sclera, or we can suture a pre-existing capsular tension ring which has been implanted at the time of the cataract surgery, or we can insert a capsular tension segment, or suture a pre-existing capsular tension device. So what suture material should we use? It should be permanent, and we know from the literature that polypropylene 10O hydrolyzes over 5 to 10 years, and it's not really suitable today. We would prefer to use a 9O polypropylene, or what I've been using most commonly is polytetrafluoroethylene, or we call Gore-Tex, and the suture I use is CV8, which is 7O Gore-Tex. It's off-label use for scleral fixation, but it has had excellent longevity, and this is the reason why I'm using it. So I'm just going to show you this technique, which has been published in the British Journal of Ophthalmology, because I'm going to use it repeatedly so that you can understand what this is about. So we're going to use this as a suture snare to help us in our surgery. And we use a 27, or today I've been using 27 more than 26 gauge needles. And we thread Gore-Tex 7O, which has been cut, a short segment that has been cut, and we thread it through from the bevel point, and then we capture the end with a tuberculin syringe so that it does not slip out, and if the suture trails behind, it doubles on itself. So we can then insert this at the scleral fixation point with this suture double on itself, and we can extend it next with a Coughlin hook, and this then forms a snare, which we thread on a suture that we wish to bring in from the incision point, preloaded onto a capsule tension device here to the scleral fixation point. This snare will then loop on the suture, and as we pull it out from the sclera, it then brings the suture along with it, and we have had a nice transmission from this end, from the incision to the scleral fixation point, and this is then repeated for the other end. So this is what we call a suture snare. I'm going to show you a common scenario that I see. So this is creating the snare, just threading it, and it really takes seconds to do, okay? And we're going to use Hoffman pockets in order to spare the conjunctiva, so dissecting from clear cornea backwards into the sclera, marking a 1.75 mm posteriorly, and I'm then going to create 2 paracenteses. All right, so you'll see here that I'm just going to directly suture behind the haptic and the capsular bag. So that's a snare that carries a free suture through. I'm repeating this with the needle above the haptic and threading the other end of the free suture and pulling it out at the scleral fixation point. I'm going to repeat it for the other side. So this is actually completely loose now. This is passing behind the haptic in the capsular bag. This is the loop of the snare, which then draws the free suture to scleral fixation point. And then we're going to do this with the needle above the haptic. And so now we have this suture which is looping around the haptic. And we then retrieve the sutures from the Hoffman pocket with a Sinskey hook. And we're doing it for the other side as well. And once we have these 2 out, we're going to look at the centration of the RL as we apply the tension and throwing a 2-1-1 kind of a knot. We don't want a big bulbous knot there that may erode. And these pockets need to be deep enough. But you can see this is something that we can do very easily. You don't need even infusion. And it's important to note how you apply these sutures, one above, one below, and then we have the knot there. And the other side should be opposite it so that it's an anti-torque force so that we do not rotate this RL. I'm going to show you another case here, and this patient has had a toric lens and also a capsular tension ring placed in, right? So this lens is really freely dislocated posteriorly. Going to remove any vitreous, very important, before you pull. You have to clear all the vitreous attachments. And again, we're going to use the suture snare. But this time, we're going to use a different suture. And this is described by Sergio Canabrava from Brazil. We're going to use Gore-Tex, we're going to use Proline 6O, one passing below, and in a similar fashion, the needle now passes above at the scleral fixation point of 1.75 mm posterior to the limbus. And this is 6O Proline that is threaded one above, one behind. And we do the same with the opposite side. Okay, so we have marked it. And because it is stiff enough, it can thread through a 27 gauge needle. And we do the same with the 6O Proline. And so now we have the sutures looped above, from behind to above, and we have it secure on both sides. And this is the time we're going to use our cautery. We're checking to make sure it's well centered. A peripheral iridotomy is created here. And we're going to create a flange with, in this case, is that low temp cautery. And the tension is important. You apply the tension there, check the centration again. Once you're happy with the centration, then you flange the other end so that you have actually spared conjunctiva and we have not had to do any dissection into the sclera at all. You do it the same for the other side without adjusting the tension any further because your lens is well centered. And then you make sure that this flange is buried inside the sclera and you pull the conjunctiva over it. So this is one behind the other, all right? So I'm going to show you another case here. This patient, I had done the surgery many years ago, had to put in a capsular tension ring because the zonules were weak in one sector, but over time, this lady returned because her lens had dislocated. And you can see here, this is doing vitrectomy first through the pars plana with a single port there with the anterior chamber maintainer. I use a 23 gauge here. And once you hold on to the IOL, you must not pull so that you do not apply traction on the vitreous. And you can see because this had flipped totally, I had to flip it around, making sure that I had cleared all the vitreous. And this again, you can see is a toric lens. So I'm going through the capsular bag from behind both the tension ring and the IOL, which is a single piece, which I'm not going to explant. I want to preserve the ability to correct toricity, right? So the other goes above. This is a suture snare using Gore-Tex 7O, also known as CV8. Now, once I've done that, I'm holding on to the IOL with the CTR, and it's useful, you know, if you have loose zonules. If you have implanted a CTR at the time of the first surgery, you can actually suture around both the haptic as well as the CTR to give a more secure hold of the IOL. So again, above now with a free suture. So this suture now loops around the IOL, and we've actually got the toricity aligned to her original axis to correct the astigmatism correction that she enjoyed all the years before the lens subluxated. Adjust for the centration of the IOL and do a 2-1-1 suture and make sure that your tension is appropriate so that the IOL remains centered after you've finished your sutures, and then you can give this patient good vision. Now we're going to look at this other patient who happens to be an orthopedic surgeon. He had his surgery done 4 years prior, and he's got a toric lens, quite a high diopter of astigmatism, and the surgeon who referred wanted me to preserve this lens. So you can see the toric marks aligned with the mark of the axis it should be repositioned to. In this case, I'm hooking up the bag, right, with iris hooks on either side of the axis, where I'm going to place a tension device to support this area of the capsule, right? This has given way, so I'm putting in a capsular tension segment, which I've preloaded with the Gore-Tex 7O. I've removed Somring's ring, part of the lens material there, so that this capsular tension segment can fit in comfortably, right? This is actually a 5 mm length, so it needs at least 4 clock hours of dissection. That's important to know, so that this will sit nicely inside the capsular bag. And you'll be surprised, 4 years after the surgery, we are still able to open up this capsular bag, insert a tension segment in, and then use a Hoffman pocket to secure this IOL. This is another patient who has got a multifocal toric lens, and you can see this is a plate haptic. So it gets even more difficult to fixate this. And the whole lens bag is free floating. So again, we've marked the axis that we want to reattach this to, the alignment marks here, and we use iris hooks, right? Sometimes we need to hold on to the capsule just to get the hook on. And once we've got the hooks in place, we know the alignment is appropriate, we can then proceed to remove any vitreous. I'm going from behind because this plate is so huge, and I've got it secured in place, and we make sure that with the aid of triamcinolone that's diluted to 50%, we remove all vitreous. We don't want to have any complications with the retina, very important. And then we're going to open up the capsule bag so that we can secure the IOL. So in this case, I'm going to put a tension segment here, where I've cleared up the cortex here, so it's dissected free, and this is the point of fixation that I've chosen for the appropriate axis placement. And again, we're using the suture snare with a 26 gauge needle. In this case, you can use a 27 gauge needle, one above and one behind, and we can then retrieve these sutures from the Hoffman pocket using a Sinskey hook. We do the same for the opposite side. These procedures do take time, but really they give very rewarding outcomes with very satisfied patients. So you adjust then the tension to make sure that this IOL is well centered after having gotten the alignment right from the outstart of this multifocal toric lens. So I'm going to show you another case here where things didn't go quite so well. All right, it looks like it's so simple that we can always open up the capsular bag and put in the tension segment. Well, I thought I could. It looked like another case of toric monofocal IOL that I had shown earlier. So here we are. We knew exactly which axis we had to place this at. I hooked up the bag, right? Put the alignment, looked at the centration, was happy about it. And I was happy talking, and then suddenly I saw this line here. Okay, so be very careful. You think that everything is going fine. The bag looks like it's opening, but it's actually ripped the capsule. So what is plan B? So I'm still going to fixate this. In fact, the surgeon assisting me, this is his cousin, so wasn't going so well for me. But here I'm using the ASI anchor by Ehud Asia, made by Hanita lenses. And this actually, you can see, hooks onto the anterior capsule rim and does not require the equator of the bag to be intact, right? And this device, the stem of the T goes above the capsular bag. So we don't need to dissect that much either. It's just a very short segment that you need to dissect to place this device to support the bag, although the support here is much narrower than what you can achieve with the tension segment. So again, using the suture snare, we slip this in, right, so that the anchor is against the capsule rim, and with the Hoffman pocket here, we retrieve the sutures, and then we can get this lens again well supported and in good alignment for this toric IOL. I'm going to show you this last case here. This patient I had done several years ago with tenofovir. All right, she was having a 2-point fixation with a toric lens implant. And what you see dislocated here is not just the IOL within the capsular bag, but also a capsular tension ring, a Sioni 1L capsular tension ring, and a capsular tension segment. So there are 2 points now to fixate, all right? And I have to align the axis. Okay, now how are we going to thread this? Now just have a look. I'm extending the suture, I'm placing the ring over the suture, and I'm threading the Gore-Tex through the eyelet. Okay, now there's one little trick here. When you do this, the Gore-Tex is quite broad and thick, and your forceps cannot grasp it through the eyelet because it cannot open widely enough. Okay, so what you need to do is before you grasp it through the eyelet, you need to squeeze that suture so that it presents a narrowed kind of profile. Watch it again. I'm going to put the eyelet over it, and I'm going to pull it through. Okay, so this is slightly crimped so that it's narrower than the actual suture normally is, and that allows you to just grasp it through the eyelet of an implant that's already in the eye, the tension segment that's already in the eye, and then you can again refixate through these eyelets, and you can spare the bag, all right? So you don't have to put your needle through this bag, and you can nicely support this, all the devices within the capsular bag nicely in place and correct this lady's astigmatism once again. So in summary, Gore-Tex 7.0 is really a user-friendly suture for scleral fixation, and I encourage you to use it. It's really very strong and it's flexible and it knots very easily. You can anchor it, the IOL directly to the sclera, or you can use through the capsule, or you can insert a device like what I've shown in many cases. And also very useful today, available to us, is the Canabrava technique, which uses flanched polypropylene 6.0, which bears the conjunctiva. Thank you very much.
Thank you, Professor Chi. It's whatever video that he showed her, it was looking so simple, but I can assure you, definitely it takes time for most of us to acquire to that kind of proficiency. And looking those, watching at those videos, it was looking as if anything you give her, she will make it right.
Thank you.
Thank you very much for your lovely presentation. And now I'll invite Professor Harminder Dua for her second talk, Unidirectional Scrolling of Descemet Membrane, Why?
So this is a very short talk, so I won't keep you long away from your lunch. But again, tells you a point that always question what you read if the evidence does not stack up. So all cornea surgeons know that the Descemet's membrane always rolls with the endothelial cell outside. So when we do a DMEC procedure, we take the Descemet's membrane out, the endothelium is outside, the Descemet's membrane inside, and the same happens with PDEC tissue. So when you make a bubble, the type 1 bubble, which has the pre-Descemet's layer, Descemet's membrane, endothelium, you can cut it out or you can refine it, and then you can get this piece of tissue. This one scrolls less than the DMEC tissue, but it also scrolls with the endothelial cells outside. This scrolling is absolutely crucial for us to get the right orientation when we open it in the eye. But nobody has been able to clearly explain why it scrolls in that manner. So if you look at this montage here, this is PDEC tissue, 4 different samples. And from this tissue, if you very carefully peel away the Descemet's from the pre-Descemet's layer and you lay them side by side, the pre-Descemet's layer scrolls less, but the Descemet's membrane scrolls much more, and this one is in between the two, as you see in all. So most of the scrolling of PDEC tissue is also imparted by the Descemet's membrane, because the pre-Descemet's layer on its own scrolls less than the PDEC tissue does. So here you can see the statistically different scrolling of PDEC tissue, DMEC tissue, and the pre-Descemet's layer, Dua's layer on its own. So everybody has said it is because of the elastin in the Descemet's membrane. Now that's true. Descemet's membrane has elastin. So if you measure the elastin of the different parts of the cornea, the pre-Descemet's layer and the trabecular meshwork have a very high concentration of elastin. In fact, the pre-Descemet's layer has more elastin than the Descemet's membrane. And this has also been shown by on-face scanning electron micrography by somebody else, another group, Keith Meek's group in Cardiff, and they've shown there is a lot more elastin in the pre-Descemet's layer. Now look at this staining. All that is green is elastin. So this is the pre-Descemet's layer, has elastin all over it, all through the tissue. This is Descemet's membrane from here to here. And are you seeing my, no, you're not seeing my, sorry, my arrow. So once again, this is the pre-Descemet's layer, and all of it is elastin, and this is the Descemet's membrane from here to here, but the elastin is only concentrated in the band in the anterior 1/5 or 1/6 of the membrane, corresponding to the banded zone of the Descemet's membrane. Here what you can see is this is PDEC tissue. So the pre-Descemet's layer is there. There's the band of the Descemet's membrane, and here you can say where half of the pre-Descemet's layer has been taken away. So you can see that's PDEC tissue here, and that's DMEC tissue. So that's the difference. Now, if you take a rubber band and you pull it and you leave it, so then you'll find it'll go like that, it'll come back. But if you take a rubber band and you pull it and you stick it to a piece of paper, when it comes back, the paper will roll that way. And that's what exactly happens here. The elastin distribution is what determines the direction of the scroll. Because the elastin is here, it rolls that way so that the endothelium is outside. It's like the rubber band stuck to a piece of paper. And if you look at the whole cornea section, that is stroma, that's a keratocyte, you can see the pre-Descemet's layer very clearly different in its elastin content. That's the interfacial zone where it's dark, and that's the Descemet's membrane with the band. So it's not just in the separated tissues, but it is also in the whole cornea that you see this unique distribution of elastin in the predescemet's membrane, predescemet's layer and the Descemet's membrane. Now, the proof is in this diagram here, this montage. That is Descemet's membrane, nicely scrolled, endothelial cells outside. And if you put some elastase enzyme and leave it, in front of your eyes, very slowly, the whole thing opens up. The scroll is gone. And then if you make a section of this that is unscrolled, you will find the whole elastin band is completely degraded and fragmented compared to the control where it is nice, smooth, and uniform. And interestingly, the lens capsule also behaves exactly the same with the epithelial cells on the outside when it scrolls, and it also has a similar distribution of elastin. Now, in the books, it has been written that this scrolling occurs because of the swollen endothelial cells of the DMEC tissue. So by the time you take it from culture, from the eye bank, and you take out the Descemet's, the endothelial cells are stressed, they're swollen, and they push it to roll like that. Now, that's what's written, but if you take a sheet with cells on it, and you treat lightly with dispace and get rid of all the endothelial cell, it will still scroll in the same direction, telling you that the swollen endothelial cells, which the textbook says, is actually got nothing to do. So how these people came to that conclusion, just because they thought it might be, but there was no evidence. And so that's what happens. This is the predescemet's layer. It acts like a rubber band. This is Descemet's membrane. It scrolls that way, and that's the this is the DMEC tissue, and this is the PDEC tissue, where the PDL is there. So most of the scrolling is with that of the Descemet's membrane. Now, the question that finally asks you is that God did not put elastin on the Descemet's membrane so that we could do DMEC. It is there for a physiological purpose. And what might that physiological purpose be? So you can imagine the cornea is convex like that and concave internally. The Descemet's membrane has to be applied to the cornea like that, right? Now, Descemet's membrane anterior surface, endothelial cells here. Now, what keeps the Descemet's membrane always attached to the back of the cornea is this elasticity, which makes it want to go like this. It wants to go like that, therefore it's stuck to that tissue there, and it can't go like, but it keep it compressed. And there is nothing holding them, nothing physical between Descemet's membrane and the predescemet's layer. Yet that apposition is so important for the endothelial cells to work and pump out the water from the cornea. So this elastin is what is allowing it to hold its position and without any physical attachment. So that's the physiological role. And this paper, as you saw at the beginning, we have a number of authors, and I'd like to acknowledge them all, and including Dr. Said, who is here in the audience. Thank you very much.
No, thank you, Professor Dua. Now I think whatever just now he talked in his first talk, and there he said, if you could remember, that you have to have a question, find the answer, and then you should be able to question that answer. So in that, because most of us probably will stop at that place, that okay, just it folds every time like that. But then going further and further, and why it is happening like that, this is what makes Professor Dua outstanding man, something one out of the crowd. So thank you, Professor Dua, for giving us such a nice idea and such a nice talk and inspiration to most of us. And I also thank Professor Chi for showing us wonderful surgeries and showing us some technique how to make complicated things look very simple, and you can make everything right at the end. This is what our aim is. Thank you very much, Professor Chi. With this, I think we are just on dot time, and the session is over. We can disperse, or if there is some other session, next session, we'll continue on. I see people with fancy dresses, the fancy people. These are also all outstanding people. Thank you very much, sir.